from the living or brain dead donor, and this kidney implanted into the patient of end stage renal disease. So one is donor, other is recipient. So kidney is removed from the healthy kidney removed from the donor and implanted into the recipient who is suffering from the end stage renal disease. So what are the options of the renal replacement therapy of end stage renal disease? Regarding the treatment, there are two options. One is dialysis, lifelong dialysis, hemodialysis, and peritoneal dialysis, or CAPD, continuous ambulatory peritoneal dialysis. Regarding kidney transplant, there are three types of the transplantation: live related donor, live non related donor, and cadaveric or brain dead donor. So, the causes of the end stage renal disease, as already discussed in the previous lecture, diabetes and chronic GN and hypertension is the contributing factors that leads to end stage renal disease. After that, stone disease can cause a problem, chronic pyelonephritis, recurrent UTI, and scarring of the kidney. Now, what are the indication of the renal transplant? TX means transplant. Basically, renal transplantation is the form of renal replacement therapy for these end-stage renal disease patients. The treatment choice in the majority of cases of end-stage renal disease is renal transplantation. The renal transplantation is the good option for treating the end-stage renal disease, either due to bilateral small shrunken kidney in which creatinine clearance is less than 5 ml per minute. Regarding the contraindication for renal transplantation, consider the renal transplant as a first choice in all patients with end-stage renal disease between 5 to 60 years, but except what are the conditions in which it is contraindicated, like infections, tuberculosis, or recurrent UTI. First treat these conditions, then you can do the kidney transplant. Or diabetic foot, gangrenous foot, osteomyelitis, CMV infection. So first treat these underlying problems, then you can do the kidney transplant. Malignancy, uncorrectable ischemic heart disease problem, psychosis, or whose patient is non-compliant, non-willing, chronic liver disease, patient suffering from hepatitis B virus and HIV. So first treat the HB hepatitis B, then you can do the renal transplant. So regarding the types of the transplantation, there are some terminology which is used. Isograft twins means transplanted tissue between identical twins, both identical twins, that is called isograft. Allograft, graft from genetically non-identical donor of the same species as the recipient, that is called allograft. Xenograft, transplantation from one species to another, like from animals to other species, so that is called xenograft. So now coming to the selection of the kidney donor, There is the exclusion criteria for live related kidney donation. The age, the, the kidney donor age should not be less than 18 years, or it should not be more than 60 years. There is no history of hypertension. It should not be hypertension, hypertensive, diabetic, or proteinuria more than 250 milligram per day, or creatinine clearance is the less than 80. Microscopic hematuria, history of recurrent renal stones, or other various urological abnormalities. Obesity 30% or above, autosomal dominant polycystic kidney, but kidney transplantation is not contraindicated if the kidneys are not huge and not creating the recurrent infections, or consent, valid consent is very important. Regarding the donor evaluation, how you evaluate the donor, history is very important. Are you, what is the age of the patient, what is the sex, weight of the patient, obesity and these things, history of diabetes, history of hypertension. We should rule out from the history of malignancy or recurrent infections. A biocompatible should be present, and routine lab tests, among the routine hematological, CBC, renal profile, liver profile, and 24-hour urinary protein urea and creatinine clearance. We should do the CME, hepatitis B virus, hepatitis C virus, HIV. Exclude the UTI by doing the urine culture. Underlying lung pathology, X-ray chest, and ECG should be done. Isolate MAGE, IVP, intravenous pyelography, and renal angiography to see the status of the renal vessels, renal veins, and renal artery. Now, how will you prepare to the patient transplant surgery? First of all, anesthetic evaluation of both donor and recipient. You should rule out the underlying comorbid, and good dialysis prior to surgery should be done. Antiseptic bath for recipient and donor at night prior to surgery. Strict barrier nursing for recipient, and we should start immunosuppressive drugs as a protocol in the recipient patient. Now coming to the operative procedures, one is called donor nephrectomy, other is kidney perfusion, and third is grafting. So usually in the native nephrectomy means patient of end-stage renal disease, the kidneys may be shrunken or normal size. So we should not remove the kidney, but sometime there are indication of pre-transplant nephrectomy. These are the infected stones, or patient has got heavy proteinuria, or due to renin secreting tumor, patient develop intractable uncontrolled hypertension, or huge cystic kidney disease, polycystic kidney disease, acquired renal cystic disease, and infected reflux. In these conditions, pre-transplant native nephrectomy should be done. So this diagram shows basically the kidney should be donated from the left side. Donor kidney should be removed from the left side, and in a recipient it should be implanted on the right side. The reason is that donor, why we select the donor on the left side, because left kidney has got, left renal vein has got long course. So you know, during anastomosis it is easy for surgeon. And why it is implanted on the right side, because on right side patient can take more care of the transplanted kidney, and there is a mm, more gutter side here. And third is the uh, on the right side surgeon has got easy to operate. So this diagram shows renal vein, renal artery. This is a transplanted kidney. How will you do the anastomosis? Renal vein in the external iliac vein, and renal vein from the donor kidney is anastomosis in the recipient external iliac vein, and renal artery, external iliac or internal iliac artery, and ureter is implanted into the bladder. So this is called anastomosis. Grafted. Now this is a graft. The kidney which is removed and it is implanted into the recipient. So various complications, surgical and medical complications can happen, like bleeding, graft thrombosis, urine leak, ureteral obstruction or lymphocyte, wound infection or renal artery stenosis. So these are the surgical complications. Regarding the medical complications, immediate complications, that is acute tubular necrosis, rejection and cyclotoxicity. This diagram is very important. Sometime after surgery, patient become oliguric. So how will you approach to post-transplant oliguria? Always first check the hemodynamic assessment, review of donor factors, check the recipient, you know the volume. If the patient is hypovolemic, give the bolus dose of normal saline 250 to 500. If urine output increase, continue replace the normal saline according to the urine output, ml to ml. If no flow, consider the exploration. If the patient is euvolemic or hypervolemic, if there is obstruction, irrigate the catheter or rule out the obstruction, then give the furosemide Lasix saline 100 to 200 milligram. If urine output increase, then continue the replacement of saline. If urine output not improved, it decrease, we should arrange the Doppler scan. We should check the blood flow. No flow or good flow. No flow, consider exploration. It means there is the obstruction. If there is a flow is good, so it indicates the delayed graft dysfunction. What are long-term complications? The long-term complication occur due to infection, CME, herpes, tuberculosis, pneumocystis carinii, and fungal infections. Rejection can occur, cyclosporin toxicity, recurrence of the disease, de novo glomerulonephritis, dyslipidemia, post-transplant diabetes, malignancy, and post-transplant lymphoproliferative disorders. Regarding the immunosuppressive therapy, steroids is the cornerstone for the management of the post-transplant kidney. Then cyclosporin, which is CNI, calcineurin inhibitors, azathioprine, AZA, and monoclonal antibodies, polyclonal antibodies, mycophenolate myrtle, and tacrolimus. Now, this slide shows what are the risk factors in kidney transplantation. The risk factor in the donor, deceased donor means brain dead donor. If age is more than 65 years or less than 2 years, or died due to intracranial bleed or organ damage during nephrectomy or prolonged cold storage time, positive virology screen. So these are the various risk factors that leads to uh, problems, complication in the donors. Now the risk factor in kidney transplantation in the recipient, sensitized to donor human leukocyte antigen or HLA by multiple blood transfusion or previous transplanted kidney or pregnancy, unrecorded sensitive events, and the patient is non-compliant to the immunosuppressive drugs, vascular disease or CNI toxicity. Now, what are the factors that is in the kidney transplantation? This slide shows the both combination in the donor as well as recipient. ABO blood incompatible, large age difference with recipient means plus minus 10 years, HLA antigen mismatch, cytomegalovirus negative recipients versus cytomegalopositive donor, delayed transplant functions, rare serum creatinine after kidney transplantation. So this slide shows the various types of the kidney allograft rejection. Means kidney reject. There are types of the rejection is hyperacute, accelerated acute, acute rejection and chronic rejection. So there are four types of the rejection: hyperacute, accelerated acute, acute rejection and chronic rejection. Hyperacute usually occur on the in the operation table, onset after transplantation, minutes to hour. It is due to sensitized recipients, and accelerated days and acute days to month, chronic month to year. So what are the causes of hyperacute rejection? Already preformed antibodies, multiple blood transfusion, multiple pregnancies, or already rejection in kidney transplant. In accelerated acute rejection, memory, cellular, and humoral immune respond to donor HLA, and acute cellular and humoral immune respond to donor antigens. So, how will you diagnose? Diagnose should be done by the grafted biopsy. So, various findings which can be present in case of the hyperacute, acute, and chronic rejections. So this slide shows the antibody preparation for renal transplant immunosuppression. There are two types of the antibodies, monoclonal and polyclonal. Indication, induction phase, rejection, and mechanism of action. So OKT3, it is given in the both induction and rejection phase. and it can cause lymphocyte depletion. Basilizumab and deculizumab induction phase, and it is not recommended in the rejection phase. It does not cause the lymphocyte depletion. Among the polyclonal antibodies, ADGAM and thymoglobulin, so they are given the induction phase and rejections. It can cause the lymphocyte depletion. So, what are the potential advantage and disadvantage of the depleting antibody induction? The advantage, it improves the graft survival for high risk patients, and period of delayed graft function may be foreshortened. Onset of first rejection is delayed. The potential disadvantage, risk for first dose reaction. It may prolong hospital admission stay and graft cost, greater cost because drug is costly, higher incidence of CME infection. So, what are the clinical use of the immunoglobulin preparation transplantation? Immunoglobulins are usually given to reduce the high level of preformed antibodies, HL antibodies in sensitized patients that await the deceased donor transplant to facilitate the living donor transplant of positive cross-match of ABO incompatibility to treat acute humoral rejections. So, after kidney transplantation, patients should take the lifelong immunosuppressive drugs to avoid the rejections, chronic rejection or acute rejection. Convention protocols, cyclosporin, three drugs, cyclosporin, MMF, steroid, or tacrolimus, MMF, steroids. So MMF and steroids are mandatory, or sometimes MMF is replaced by azathioprine, or AZA is replaced by MMF, cyclosporin, sirolimus, and steroid, tacrolimus, sirolimus, and steroids. So these are the different types of protocols. In our countries, here usually we use the cyclosporin, azathioprine, and steroid, but in good setup, the cyclosporin, mycophenolate mofetil, and steroid can be used. So this slide shows the what are the risks of the recurrent disease after renal transplantation. That is called de novo disease or de novo GN. FSGS is 30 to 50%. IgA nephropathy, MPGN, MPGN2, membranous nephropathy. After renal transplant, patient can develop these diseases. Diabetic nephropathy, microangiopathies that comprises of hemolytic uremic syndrome and thrombotic thrombocytopenic purpura, that is 50 to 75%. Oxalosis 80 to 100%. Wegener's disease, Fabry's disease, SLE. So this is the last slide that shows the delayed graft dysfunction. What are the differential diagnoses? If the graft dysfunction delayed, top one of the most causes acute tubular necrosis, then intravascular volume contraction due to hypovolemia, arterial occlusion due to thrombosis, arterial thrombosis or venous thrombosis, urine leak from the ureter and bladder anastomosis, hyperacute rejections, nephrotoxy, and TMA, thrombotic microangiopathy, that comprises of hemolytic uremic syndrome and TTP. So this is all about the renal transplantation. So thank you very much.